So welcome to the second section of the cornea. In this session we will cover about the welcome to the second session on the cornea. In this session we will cover the topics about the corneal investigations and the corneal ectatic disorders, corneal dystrophies and corneal keratoplasty. So the most important among the corneal surgeries is the corneal keratoplasty. It is basically the corneal transplantation. Corneal investigations. The first is the keratometry. Keratometry is done to evaluate the curvature of the cornea, and it is represented in the dioptric power. So the normal dioptric power of the cornea is ranges between 40 to 46, and it is the keratometry, which is to evaluate the curvature of the cornea, is done by the keratometer. So if the cornea has the more curvature, the dioptric power will be more, but if the cornea is flattened, the dioptric power will be less. The second investigation of the choice is the pachymetry. It is to determine the thickness of the cornea. So as I told you earlier, the central part of the thickness has 450 to 550 microns, and the peripheral part has thickness of 700 to 900. So pachymetry is done to determine the thickness of the cornea. Then if we to analyze the corneal surface, that it has depressions or the elevations on the surface, then what will we do? Then we do the topography. It is to analyze the corneal surface. And the tomography, it is better than the topography, because in this we analyze the corneal surface as well as the thickness of the cornea. So tomography is better than the topography. Next is the specular microscopy. It is to study the endothelium of the cornea, and one of the most important clinical application, it is to determine the donor tissue for the keratoplasty, to determine the quality of the donor tissue for the corneal transplantation. So if the endothelium is less functioning in the donor tissue, then it will not be acceptable. It will only be acceptable on the basis of the endothelium, and it is only done by the specular microscopy. What are the investigation? Keratometry to analyze the curvature, pachymetry to analyze the thickness, topography to analyze the surface of the cornea, and tomography to analyze the corneal surface as well as thickness, and specular microscopy to analyze the endothelium. And one of its clinical application is prior to the keratoplasty, to determine the evaluation of the donor tissue. And the corneal topography. So this chart shows the corneal topography of a normal cornea. So in this, the values are coded in the colors, and there is a circle showing the values. So here it shows that the values are coded in the green. So green has the range from 40 to 46, and it is the normal dioptric power of the cornea. So this shows that the curvature of the cornea is normal, but if it is in red higher than the green value, then it will shows the abnormality in the cornea. So this test is called, investigation is called the corneal topography, to analyze the surface of the cornea. Then we have the corneal tomography. So I told you that the tomography is better than the topography, because it has like 4 maps. So the first map is showing the curvature of the cornea. Suppose this is the area, and it's showing the curvature of the cornea. Then map 2, it shows the interior surface analysis. If there is elevation or depression on the interior surface, then the second map will shows the anterior surface, and this area is covered as here, here and here. So this area or this map will shows the posterior surface analysis, and the last one shows the thickness of the cornea. So it will shows the thickness of the cornea. So it has the 4 maps. One is the topography, like the curvature of the cornea. Map 2 shows the anterior surface, and the map 3 shows the posterior surface, and the map 4 shows the thickness of the cornea. In this way, the tomography is better than the topography. The last one is the specular microscopy. So the specular microscopy, this is the procedure, and this is the diagram which presentation of the endothelium. So it gives the endothelial count, how much the endothelial cells are present, and the normal endothelial has the hexagonal cells, and they are like tightly packed with each other. These normal endothelial characteristics. So now we have the corneal ectatic disorders. In this we will study about the keratoconus, keratoglobus, and the pellucid marginal degeneration. Keratoconus, by definition, it is the non-inflammatory corneal ectasia. So what ectasia means? Ectasia means the protrusion of the cornea. Protrusion associated with the thinning. So it is bilateral and asymmetrical. Asymmetrical means that the one eye has the advanced type of the keratoconus, and the other eye can have the early stage of the keratoconus. So it is the abnormal protrusion with thinning. See, we can see this is the abnormal protrusion of the cornea with the thinning. This is the abnormal protrusion with the thinning, and this is called as the keratoconus. Now we come to the most common cause of the keratoconus. So the most common cause of the keratoconus is the frequent rubbing of the eyes, and it happens mostly in the viral keratoconjunctivitis. In children, due to the viral keratoconjunctivitis, they frequently rub their eyes, and it leads to the keratoconus. So what are the complications due to the keratoconus? It results in the irregular myopic astigmatism, as there is disturbance to the curvature of the cornea, and we also don't know which part of the cornea will protrude and how much it will protrude. So there will be irregularity and myopic astigmatism. So what happens due to the irregular myopic astigmatism? There is frequent change of the glasses. As there is irregularity of the myopic astigmatism, their child will continue to change the glasses frequently and are uncomfortable with the glasses, as there is no prognosis of the astigmatism. So they will uncomfortable with the glasses and continue to the change. And if we do the retinoscopy, there is Caesar reflex on the retinoscopy. So there is like Caesar reflex on the retinoscopy. What are the signs we observed in the keratoconus? One is the Masson signs. So it is the V-shaped indentation of the lower lid when the patients look downward. As the patient looks downward, there is V-shaped indentation of the lower lid. This is called as the Masson signs. Next is the flessuring. What is flessuring? As due to the curvature of the cornea, the tear film is not equally spread on the cornea, so there is iron pigment ring forms at the base. So at the base there is formation of the iron ring in the cornea. It is called as the Flescher's ring. The next sign is the Vacot stria. So stria on the decimal membrane, which is the toughest membrane of the epicornea due to the pulling effect, and they are in vertical. So due to the pulling effect of the decimal membrane, there is a stria, and it is called as the Vacot's stria. This is the Vacot stria. If there is tear in the decimal membrane, so the aqueous humor gushes into the cornea, and the cornea becomes edematous and the hazy. and it is called as the hydrops. So if there is tear in the descendants membrane, the aqueous humor will flow and comes in the cornea. The cornea become edematous and hazy. It is called as the hydrops. What are the investigations for the keratoconus? So for to evaluate the increased curvature, we do the keratometry, and for decreased thickness of the cornea we do the pachymetry. So on keratometry there is increased curvature, and on pachymetry there is decreased thickness. And then we do the topography. Suppose this is the topography image of the keratoconus. So this is the localized area, and it shows the values of the 47.5, and it is in the red color. So this shows the increased curvature of the cornea. Then the investigation of choice is the tomography. So in tomography there are the 4 maps, and the map 1 I told you earlier that it is like of the topography. So here this is the localized area, and it shows the values 54.5. So it shows the increased curvature of the cornea. And this is the map 2, which shows the anterior surface elevation. So this is the localized area. So it shows the increased elevation on the anterior surface, and this is the posterior, shows the posterior elevation, and this is like the pachymetry, and it shows the decreased thickness. So in the keratoconus there is increased curvature and there is decreased thickness of the cornea. We also need to remember the association of the keratoconus. It is venereal, cataract, VKC, Marfan syndrome, Down syndrome, and Ehlers-Danlos syndrome. So in these conditions we are able to see the keratoconus. What is the treatment of the keratoconus? So first is to treat the irregular astigmatism. For this we use the rigid gas permeable contact lenses, RGP. So irregular astigmatism can be corrected by the use of contact lenses, which is rigid glass permeable. And as the curvature of the cornea is very high, the contact lens is not able to stay on the cornea. Then we can do the C3R, corneal collagen cross-linking with the riboflavin. So we cross-link the contact lens with the riboflavin. So it is called as the C3R. In this way the contact lens will able to stay on the cornea. What is the treatment of the keratoconus? So in the keratoconus there is main problem of the irregular astigmatism. The child is not happy with the glasses, and then we can use the contact lenses. The contact lenses are RGP, rigid glass permeable. Next, the curvature of the cornea is very high. The contact lens is not able to stay on the cornea. Then we can use the C3R technique, in which the corneal collagen cross-linking with the riboflavin. In this, the riboflavin is cross-linked with the corneal collagen, which helps to flatten the cornea, and in this way the contact lens can stay on the cornea. Next procedure is called intracorneal ring segments, in which certain segments of the ring is inserted into the cornea, and it will also correct the irregular astigmatism. And then the keratoplasty is the corneal transplantation. In the advanced cases we do the keratoplasty. Next disorder is the keratoglobus, in which the entire cornea is protruded and thinned out. In this, as we can see that the entire cornea is protruded and the thinned out. So it will result in the high myopia because of the increased curvature. The image will fall in front of the retina, so it will result in the high myopia and high risk of the cornea rupture. part of the cornea is protruded and thinned out, it is called as the keratoconus. The whole of the cornea is thinned out and protruded, is called as the keratoglobus. The association of the keratoglobus is the osteogenesis imperfecta and the Leber's congenital amaurosis. So Leber's congenital amaurosis is also a hereditary group of congenital retinal dystrophies, in which we can see the keratoglobus. And what is the treatment is the scleral contact lenses. The scleral contact lenses has the large diameter as the whole of the cornea is protruded and thin out. So we will use a contact lenses that cover the sclera and the cornea. It will cover the sclera and the cornea. These are called as the scleral contact lenses. One is the pellucid marginal degeneration. So in this there is thinning of the cornea from position 4 to 8 o'clock. So this is the thinning of the cornea, and the protrusion is above the thinning. So it affects the inferior cornea. It will affect the inferior cornea, and there is thinning below it and the protrusion above it. So the crescent shaped band of the corneal thinning from 4 to 8 o'clock separated from the limbus. Protruded cornea lies just superior to the band of the thinning. So the protruded cornea will lies above the thinning, and there is irregular myopic astigmatism. The treatment is RGP contact lenses, rigid gas permeable contact lenses, to correct the problem of irregular astigmatism. So the other sign of the in the corneal ectatic disorders is the enlarged corneal nerves. So due to the thinning of the stroma, we see the corneal nerves prominency. So due to the thinning of the stroma, there is, we can see the corneal nerves. So in these conditions, the enlarged corneal nerves, we can see this is the neurofibromatosis, MEN2B, Refsum disease, acanthosis, amyloidosis, leprosy, herpes simplex virus keratitis, and acanthamoeba keratitis. Next topic is the corneal dystrophy. So dystrophy means the abnormal tissue which is present since birth, but the manifestation of disease at any age can occur. So we have the epithelial and the Bowman's membrane dystrophies. These are called as the superficial corneal dystrophy. The epithelial dystrophy, these are of two types: Kogan microscopy dystrophy and the Meesmann and Stocker dystrophy. We have to remember the names of the dystrophies: epithelial Kogan microscopy dystrophy and Meesmann's and the Stocker dystrophy. And what about the Bowman's membrane dystrophy? It has the following types: Rees-Buckler dystrophy and Thiel-Benke dystrophy. So there is recurrent corneal erosion occurs because the corneal epithelium is not adhering properly to the underlying corneal layers. So these kinds of patients presents with eye pain on waking and a history of repetitive episodes of the corneal erosions. What is the treatment? Treatment is the phototherapeutic keratectomy to reshape the cornea, in which we use the excimer laser is used. Next is the stromal dystrophy. The stromal dystrophy is the deposition of the foreign substances in the corneal stroma. So the third layer of the cornea is the stroma. So if there is deposition of the foreign material in it, then it will results in the abnormal tissue. So we have the lattice dystrophy, in which the amyloid substance is deposited and the dye used is the Congo red. Next is the granular dystrophy, in which the hyaline is deposited and the dye used is the Mason's trichome. Then Avellino dystrophy, in which the granular and the lattice both type of substances, amyloid and the hyaline, are deposited, and the macular dystrophy, in which the maculopolysaccharides is deposited and the Alcian blue is the dye used to identify it, and the gelatinous drop-like dystrophy, in which the amyloid and the stain dye is the Congo red, and the Schenter's crystalline dystrophy, in which the phospholipids are deposited and the oil red O is the dye used for it. So we have the lattice dystrophy, granular dystrophy, Avellino dystrophy, macular dystrophy, gelatinous drop-like dystrophy, and the Schindler's crystalline dystrophy. In the lattice and in the gelatinous, we have the amyloid and the stain is the Congo red. In the granular, we have the hyaline and the is the Messon's trichome dye used, and in the macular we have the maculopolysaccharide and the Alcian blue is the dye used, and in the Schindler's crystalline we have the phospholipids and oil red O is the dye used for it. Let's see the image of the lattice dystrophy, in which the amyloid is deposited, and we see this is the presentation. And in the granular dystrophy we see multiple white dots like this in the cornea, and in the macular dystrophy we also see the white dots. But the difference between the granular dystrophy and the macular dystrophy is this, that the intervening cornea is clear. In the granular dystrophy, the distance between the two white dots is clear in the granular dystrophy, but the distance between two white dots is hazy in the macular dystrophy. Clinical features in the stromal dystrophy is the decrease in vision due to the decrease in corneal transparency, and the treatment is the keratoplastic corneal transplantation. Then we see the dystrophy at the endothelial level, in which there is dysfunction of the sodium potassium ATPase pump. The normal role of the sodium potassium ATPase pump is to the pull out water, and it results in the dehydration of the cornea, but as there is dysfunction it will result in the hydration of the cornea, corneal edema and the hazy cornea. And what are the congenital hereditary endothelial dystrophies? These are the types of the endothelial dystrophy, Fuchs dystrophy and the posterior polyphorus dystrophy. The congenital hereditary endothelial dystrophy occurs due to the hereditary conditions, and in the Fuchs dystrophy we see the specular microscopy. This is the specular microscopy of the normal endothelium, but this is the specular microscopy of the Fuchs dystrophy, in which there is deprived of the endothelial areas, and this is called as the gut tie, and the surrounding cells will come to occupy the space, and it results in the pleomorphism, change in the shape of the cells, and the polymegathism. So the corneal degeneration. The corneal degeneration, the normal corneal tissue at the birth, but due to the some causes it becomes abnormal. So the most common is the arcus senalis, in which the band-shaped keratopathy we see. Band-shaped keratopathy is due to the deposition of the calcium in the form of calcium hydroxyapatite in the cornea. It will form a whitish ring near the limbus seen in the elderly people. It is seen at the level of the Bowman's membrane. So what are the causes? It can be due to the systemic causes, hypercalcemia, and in ocular causes are the chronic keratitis, chronic uveitis, and the silicone oil. So in vitreousectomy, we use the vitreous substitute. We remove the vitreous and we use the silicone oil. Due to the presence of the silicone oil, the calcium in form of the calcium hydroxyapatite deposit in the cornea at the level of the Bowman's membrane near the limbus. It will results in the band-shaped keratopathy. So what is the treatment? Treatment is the EDT chelation. It will chelate the calcium, and if it doesn't work, then we use the phototherapeutic keratectomy, in which the excimer laser is used, and we can also do the superficial keratectomy. The next topic is the keratoplasty. It is the corneal transplantation. So for the cadaveric donor tissue, we do the from the cadaveric donor tissue we do the corneal transplantation. So what are the contraindication for the use of the donor tissue? If the donor is positive for HIV, Hep B virus and Hep C virus, and death from the head, neck malignancy or metastatic cancer. For example, if there is pancreatic cancer and it is metastasized to the other organs, and if the death of the patient occurs from the rabies, from the septicemia and prions disease, or death due to the unexplained cause. So what are the techniques used for the keratoplasty? We use the full thickness penetrating keratoplasty. A full thickness means the cornea is transplant from the donor tissue, from the epithelium to the endothelium. The whole thickness of the cornea is transplanted, and it is done in the perforated ulcer, leukomatous corneal opacity, and adherent leukoma. Perforated corneal ulcers and in leukomatous corneal opacity, there is the opacity from half of the thickness to the full of the cornea, and in adherent leukoma there is full thickness cornea is opaque. So we do the deep anterior lamellar keratoplasty. This is another type in which partial thickness transplant of the donor tissue from epithelium to the deep stroma. So in this deep anterior lamellar keratoplasty, we transplant the epithelium, Bowman's membrane, and till the deep stroma. So it is used in the keratoconus, stromal dystrophies, granular and the macular dystrophy, and the macular corneal opacity. What is the posterior lamellar keratoplasty? The decimate systemic automated endothelial keratoplasty DSAEK, in which the posterior stroma, decimates membrane, and the endothelium are transplanted. In this deep stripping automated endothelial keratoplasty, in which we do the deep stroma, decimates membrane, and the endothelium are transplanted, and the other is the decimates membrane endothelial keratoplasty, in which the decimates membrane and the endothelial are transplanted only. And in this is the indications for the endothelial dystrophy, in which the endothelial is damaged, or bullous keratopathy, in which a group of the corneal diseases occurs. What is the keratoprothesis? It is means the transplantation of the artificial cornea. It is done in one eye patient. If the other eye is not working and one eye function is also compromised, so it is done in the patients with the multiple failed keratoplasty, in which the normal cornea transplantation has done multiple times, but it is failed in Steve-Johnson syndrome and chemical and thermal burns and ocular cicatricial pemphigoid. This is the keratoplasty, in which the cornea is transplanted with the vertical suture, and this is the host pad. So this is the keratoplasty, and this image is of the keratoprothesis. So what Fuchs dystrophy? So it is the endothelial dystrophy, in which the cells are deprived of the cornea endothelial cells, and the surrounding cells occupy the space, and it results in the pleomorphism and the polymegathism. So this is one of the MCQs, image-based MCQs, in which we see the specular microscopy and we see the areas and deprived of the, and the surrounding cells will try to occupy, and it results in their pleomorphism and megathism. the corneal transplant contraindication. So we know that if the donor is HIV positive, Hep B positive, Hep C positive, rabies, that due to the rabies, septicemia, prions disease, head and neck malignancy, and unexplained cause. So corneal transplant protocols, it is transported within the 6 hours after from the cadaveric, and it is transported in the sterile moist glass chamber, and in the this is the short term preservation, and for the intermediate preservation we use the McCarry-Kaufman medium for preservation of 72 to 96 hours. What is not indication for the corneal transplant? In neurotrophic keratopathy, in which there is loss of sensation to the cornea, we cannot do the corneal transplant. It can be due to the herpes simplex keratitis, diabetes mellitus, leprosy, and brain stroke. The treatment is we use the lubricant, so the epithelialization can occur, and we do the tarsorrhaphy, in which the lateral part of the eye is sutured, and it results in the decreased evaporation of the tear. And what is the indication of the corneal transplant? Perforated corneal ulcers. We do the PK, penetrating keratoplasty, in which the whole of the full thickness cornea is transplanted from the epithelium to the endothelium, and the keratoconus, in which we do the DALK, deep anterior lamellar keratoplasty. And in the endothelial dystrophy, we do the DSAEK, keratoplasty, deep stripping, decimate stripping endothelial keratoplasty, in which the posterior stroma, decimates membrane, and the endothelial are transplanted, and in the decimates membrane endothelial keratoplasty only the decimates and the endothelial is donated. So in which conditions we cannot do the keratoparesis? In the perforated corneal ulcer, and in the perforated corneal ulcer we cannot do the keratoprosthesis. What is the indication? Steve-Johnson syndrome, ocular cicatricial pemphigoid, and the multiple failed penetrating keratoplasty. In these conditions we do the keratoparesis. What is the band-shaped keratopathy? It is the presence of the whitish ring due to the hypercalcemia in the form of the calcium hydroxyapatite due to the silicone oil presence. So the topic is done about the second part of the cornea.